Second speaker should be Dr. N.S. Loud from India. Unfortunately, he is sick today and cannot attend. And his colleague will help him to present this important talk to us.
Mr. Chairman, sir, good morning, friends. Last midweek, Dr. Loud developed a certain respiratory infection, and he was advised not to undertake air travel. So it's my privilege to give his talk. The aim of trauma management is, of course, to reduce mortality, morbidity, and disability, whether it is permanent or temporary. The components of this care would be a pre-hospital care, which is pretty important, and a hospital care. Dr. Loud was the pioneer of such services in Mumbai, probably in India, and that's why he was invited here. Good old days, 1986 was the time when he started these services in city of Mumbai. In 5 years' time, they could bring down the mortality significantly. First 5 years, mortality was reduced. Their findings were still they had significantly high mortality after pelvic injuries and cervical spine injuries, but the injuries following skeletal trauma was significantly reduced. They also introduced the concept of organ transplantation, and what follows is his analysis of pre-hospital care and his vision of entire trauma services in the country of India. Friends, traffic injuries cause a significant number of deaths annually and significant disabilities. 1990, they were probably road traffic accidents were 9th on the list, but what is going to happen by 2020 is they would be 3rd in the list as far as deaths are concerned. Today, because of industrialization, urbanization, mechanized support, violences, terrorist activities, disasters, the incidence of such trauma has increased significantly. What happens to a trauma victim is there is a mechanical derangement, physiological changes, that leads to biochemical changes or systemic inflammatory response syndrome, which may lead to death or permanent disability. Our duty would be pick up these victims pretty early so that they don't go to 3rd and 4th stage. We all know that there's a trimodal distribution of trauma deaths. First few minutes, you can hardly do anything about the deaths, virtually unpreventable. But the next an hour or so, what is called golden hour, many of these deaths are preventable. And there's a third peak, weeks or months later. Both deaths from second and third peak are potentially preventable. Trauma care in developed countries, whether in Europe or in United States, are pretty well developed, and there's as much as 50% reduction in the mortality of these following these. What is required is an integrated approach. Unfortunately, European musculoskeletal review system said that there is a serious lacunae in pre-hospital care in Asian countries. Scenario in developed countries, A, we all know, A for airway, B for breathing, C for circulation, D for disability, E for exposure, and F for splinting or fracture. Unfortunately, in most of the Afro-Asian countries, A for apathy, B for bureaucracy, C for callousness, D for difference, E for escapism. It's not my duty, typical managerial attitude, and there's a financial chaos. So one day or the other, these things have to change. So there has to be a proper policy, preventive strategies, how you are going to develop emergency care, definitive care, reconstruction, and restoration of function. As soon as there is a trauma, once alarm is raised, 3 important faculties have to reach there: the police, the fire brigade, and the ambulances, which would evacuate the victims to casualty. Police have to cordon off the site, have traffic control, and have divergence. Fire brigades should extricate and salvage the patients. And one has to have a plan, a pre-arranged emergency services everywhere in our country. An injured, how he is going to get emergency care on the spot, how he is going to get basic medical care during transport, and how will he transport it to nearest medical center. Inside the ambulance, people have to maintain airway, breathing restoration, and circulatory maintenance, apply splints, but still more important, it's not just transport and helping there, they have to keep communicating, because what is important is 3 R's: the right patient, the right hospital, and right time. It is necessary that patient is transported to the right hospital. The ambulances have to be such that they have a peculiar color or siren, and not a very bulky ambulance or not a very bulky vehicle which cannot negotiate through our small and crowded roads. The personnel should be at least 2 well-trained medical or paramedical people with adequate training in resuscitation, maintenance of airway, breathing, circulation, use of splints, and the ambulances should probably color-coded. Ambulances with excellent facilities would take really risky patients, while patients who just need to be transported can be shifted in an ambulances which do not have all these facilities. Finally, one has to realize that you just cannot take every patient to the nearest nursing home, because several patients would need really advanced care, and therefore the hospitals have to be classified into A, B, C level: A with real advanced care with super specialty backup, such as teaching hospitals or high-level medical centers, to a little lower level medical centers, and C would be areas where just routine medical management could be done at the primary health center level. What is important is analysis of what is happening at these A, B, and C centers. At the same time, research as to what is happening, what are the outcomes, as well as teaching to trauma centers, trauma surgeons, intensivists, anesthetists, and paramedical personnel. So what one has to plan, what the government has to plan, and the medical fraternity has to plan, is a total trauma care, which would consist of pre-medical or pre-hospital care from the moment go. Have a proper contact with police, the trauma ambulance, and fire brigade. The trauma ambulance will transport for help, basic research, basic life support, and resuscitation. Have a good hospital care with proper reception, which will have resuscitation, emergency surgery, as well as intensive care. What follows would be a definitive care and rehabilitation. So friends, let's plan for a pre-hospital care, which is not just a transport system, but a certain road to recovery. Thank you very much.
thank you, Dr. Ashley, for presenting to us, and especially in keeping the time so that we can have enough time for tea later. So may I remind the speaker, actually our time of presentation, 10 minutes. Actually, you have a clock outside, which help you time your speech. And then without delay, we'll go to the third talk, the damage control orthopedics, which will be presented by Mr. Alan Norris. Actually, Mr. Norris has given us an excellent talk about mechanics this morning, and we'll welcome him back for the second talk on damage control orthopedics.